I am Dr. Shushan MUKHOPADHYAY, currently Director and Chief Cardiac Surgeon at Apollo Gleneagles Hospital. Today I am going to speak on the recent trends in cardiac surgery with special interest to heart failure and its treatment with heart transplantation and LVAD therapy. As we all know, cardiac surgery and cardiac therapy has moved from improvement in drug therapy to intervention therapy, and now we are landed with a large number of patients, those who come with heart failure. Thus, we will discuss the modern trends in treatment of heart failure. Heart failure is a complex clinical syndrome and it can result from either a structural or functional cardiac disorder that can impair the ability of the ventricle to fill or eject blood. It could be a disorder of the great vessels, the disorder of myocardium, pericardium, and endocardium. Heart failure, however, is not equivalent to cardiomyopathy or left ventricular dysfunction. Now, the main clinical signs and symptoms of heart failure, the symptoms would be breathlessness, swelling of leg, shortness of breath while lying down, which is called paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigue, wheeze, anorexia, confusion, and the main signs will be elevated jugular venous pressure, hepatojugular reflex, third heart sound, laterally displaced cardiac impulse, and a cardiac murmur. However, dyspnea and edema are the most prominent symptoms, and cough is the third common symptoms in heart failure. However, other heart symptoms, as has been discussed, have been enumerated already. If we look at the class of heart failure, it could be an NY, New York Heart Association class 1, which is no limitation of physical activity, ordinary physical activity does not cause any breathlessness or fatigue, to class 4, which is unable to carry out normal physical activity without discomfort. These are severe symptoms, and symptoms can also present during rest. Now, the staging system, AHA, ACC staging system in heart failure could be stage A, high risk with no symptoms, which are usually managed by reduction of risk factors. Stage B and stage C either can be having a structural heart disease or without any heart disease, but will require medical therapy, drug therapy to control symptoms. However, the refractory stage is the stage D, which requires inotropes, nitroprusside, and therapies such as CRT and ventricular assist device or transplantation. The diagnosis of heart failure, it depends upon clinical examination. There could be symptoms and signs, and as we have already discussed, it could be a preserved heart ejection fraction heart failure or a reduced ejection fraction heart failure. And there are certain non-invasive investigation as well as invasive investigation enumerated or prescribed to diagnose heart failure. The non-invasive methodologies could be ECG, clinical examination, ECG, chest X-ray, and echocardiogram, of which the electrocardiogram and an echocardiogram is a very important tool in diagnosing heart failure. There are certain biochemical and hematological investigation which can diagnose anemia, exclude infection, determine whether the RAS blocked renin-angiotensin system blockages can be used, and the usage of natriuretic peptides can be done or not. The other invasive investigations would include a cardiac MR and a coronary angiography to find out whether there is a coronary artery disease or not. It could be complemented with an exercise stress tests also, and a left heart and a right heart catheterization. There are an array of pharmacological reagents that are devised to treat heart failure, and it could be AC inhibitors, beta blockage, ARBs, lanoxine, hydralazine, and the newer drugs are the ARNI. Now, it has been found that ARNI group is the most effective in treating heart failure. However, there are other drugs also that effectively reduce the mortality in heart failure, which could be beta blockers, ARB, AC inhibitors, etc. There are certain newer reagents which are used to treat heart failure are pathiromar and zirconium cyclosilicate, which plays a role on the calcium and sodium channels, intestinal channels, and these are coming in as a newer therapies in heart failure. Now, in refractory heart failure, when the patient is in stage 4, the therapy would include inotropic, whether in hospital or ambulatory inotropes such as dobutamine, dopamine, milrinone, nitroprazole, nitroglycerin. There could be a usage of mechanical circulatory support such as intra-aortic balloon pump and left ventricular assist device. Cardiac transplantation and LVAD are practically the last stage therapy when nothing is working. Usually, if the patient has a history of multiple hospitalization and there is a need for escalation of intensity of medical therapy, we always check the reproducible VO2 max, which has to be below 14 to qualify for heart transplantation. There are various newer therapies that are coming in, and trials are going on to test newer drugs also, which would be which is beyond the scope of today's discussion. However, but I think we'll discuss something about the surgical management of heart failure. What are the options available? The options available are revascularization therapy, valve surgery, surgical ventricular restoration, myocyte restoration or replacement, external support, heart transplant, or a mechanical support. Current cardiac surgery started with the development of cardiopulmonary bypass in the 1960s with the introduction of pacemaker, the introduction of myocardial protection, valve prosthesis, repair coronary artery surgery, and recently the trend is to treat surgically the heart failure or doing a transplantation or artificial heart or an assist device. The conventional CABG gained popularity and became the most common operation performed through the 1980s and 90s, and it's a majority of cardiac surgery performed by cardiac surgeons. Various meta-analyses has proved that CABG can improve outcomes in chronic heart failure, and even inclusion of patient with heart failure in recent CABG and versus PCI trials, the Syntax and the Freedom trial and the Bari trial has spoken in favor of CABG. CABG in chronic heart failure without angina symptoms, the Stitch trial, which has come into, the results have come in 2016, and they say that any patient with LV ejection fraction less than 35 without severe angina, there is an advantage of surgical therapy vis-a-vis medical therapy over the years. The mortality rate is low, the cardiovascular mortality rate is low, and patients with more severe disease tend to benefit more with coronary bypass surgery. A patient with and without diabetes received consistent benefit, and patient with and without angina also received consistent benefit in the Stitch patients. In young Stitch-like patients, severe left ventricular systolic dysfunction should prompt an evaluation of the extent and severity of the angiographic coronary artery disease. CABG should be considered to improve long-term survival. So, survival after coronary artery bypass surgery in patients with preoperative heart failure and preserved versus reduced ejection fraction. There is a Swedish nationwide population cohort which has significantly showed that patients with preserved ejection fraction and with a reduced ejection fraction, there was significant improvement in mortality benefit. However, in patients with heart failure with reduced ejection fractions benefited most. The evidence of revascularization cardiogenic shock, the shock trial also say that the 30-day all-cause mortality was advantageous in CABG, and the 6 months all-cause mortality was much less if the patient received CABG than medical therapy. So the CABG surgery transition, as we have seen the fancy of various surgeons when we started with on-pump sternotomy, then came off-pump sternotomy, 2 small incision surgeries which were initially done on pump, now with off pump, and this is the majority of surgery done in our center now. We are doing hybrid surgeries, like we are doing surgical revascularization in major vessels and allowing the PCI to be done in other vessels, and robotic cardiac surgery. So there has been a 2017 ESC and ESCTS guideline for management of valvular heart disease. We need to undergo see the recommendations for valvular heart disease. TAVI is recommended in patients, those who are not suitable for SAVR as assessed by the heart team, and patients with increased surgical risk also can benefit for TAVI, but however with improved results in surgery and TAVI gives equivalent results in patients with high and intermediate risk. However, in low risk group, I think still surgical aortic valve replacement holds the post. Now, mitral valve surgery for regurgitation is another treatment, surgical treatment of chronic heart failure. It could be a functional MR, which can be treated by either a plasty or a CRT. It can be an ischemic MR secondary to infarct and global LV dilatation, which will require anything more than moderate MR will require mitral valve replacement. And if it's an organic MR, it definitely requires mitral valve intervention. Now, if it's aortic valve stenosis which causes heart failure, that stenosis needs to be corrected. And it's been shown that symptomatic severe aortic stenosis with signs of heart failure needs an aortic valve replacement. Even asymptomatic severe aortic stenosis with LV ejection fraction borderline less than 50% requires aortic valve replacement. And severe aortic stenosis in patients with LV dysfunction also benefit from aortic valve replacement. In aortic regurgitation, symptomatic severe AR with signs of heart failure require aortic valve replacement, as well as patients with asymptomatic AR, those who have less than 50% ejection fraction, should be given the choice of surgery. We have data from partner 2 which shows that TAVR has equivalent to SAVR overall in the midterm group up to 24 months. However, the stroke rate seems to be a little higher in the surgical aortic ventricular replacement, aortic valve replacement. Throughout Europe, the trend is to increase in the TAVI rather than SAVI. However, in India, I think TAVI is gradually catching up with more and more transcatheter valves being implanted in higher risk groups gradually. If we look at the mortality benefits, the surgical aortic valve replacement mortality has remained more or less steady. However, for the TAVR, over the years, I think the mortality has come down, and now it is less than or equal to surgical aortic valve replacement in the 2016 and 2017. The other important aspect of heart failure surgery is surgical ventricular restoration or aneurysmectomy if a patient has chronic heart failure. If a patient has a symptomatic aneurysm, it's usually what we do is we do an endoaneurysmography to prevent energy loss into the dyskinetic ventricle. We do a surgical ventricular restoration and prevent heart failure symptoms. Now, what are the role of mechanical supports for the heart? The indications could be acute myocardial infarction with shock, which happens after myocardial infarction when a patient is undergoing PCI, or a mechanical complication of MI has developed, such as ventricular septal rupture or acute MR. When we plan a coronary intervention in a high-risk patients, in a patient with cardiogenic shock after cardiac surgery, acute fulminant myocarditis and terminal heart failure, either it's a final destination or a bridge to transplantation. The mechanical circulatory supports could be intra-aortic balloon pump, the extracorporeal system, or pumps, the intracorporeal implantable devices, and an artificial heart. The intra-aortic balloon pump is by far the most commonly used support system, which causes a diastolic inflation of the balloon and improves coronary circulation. It also relaxes the ventricle and allows the systemic vascular resistance to come down, and improves the cardiac output in cardiogenic shock. It can be a bridge to recovery after MI with cardiogenic shock with low cardiac output syndrome in cardiac surgery, myocarditis with severe heart failure, and bridge to orthotopic heart transplantation in ischemic patients. However, if there is a severe aortic regurgitation, aortic dissection, it's better not to use an aortic balloon pump. Similarly, if there are femoral artery disease, then it is better to avoid an intra-aortic balloon pump. Now, the indications of mechanical supports to the heart could be heart failure refractory to therapy with organ hypoperfusion, even on high dose of vasopressors. There are certain hemodynamic parameters that are taken into account, such as cardiac output less than 2 liters per minute, mean arterial pressure less than 65 millimeter of mercury, a pulmonary capillary wedge pressure more than 18 millimeter of mercury, a pulmonary PA diastolic with more than 20, and a CVP with more than 20. The absolute contraindications would be, however, a high creatinine, high bilirubin, severe sepsis, primary coagulopathy, tumor, and cerebral vascular disease or diseases of the aorta. There are certain relative contraindications, such as affection of pulmonary parenchyma, mechanical valves, contraindication of anticoagulation therapy, disease of peripheral vessels, and drug abuse. Now, if we look at the implantable devices, we started with the DeBakey pump. We have the HeartMate 2 LVAD system, which can, and the trials are in for initially with bridge to transplantation. Now we have destination therapy also with HeartMate 2, and there are reports of more than 11 years of good survival after having HeartMate 2. Mechanical supports of the heart, which are intracorporeal, could be impella or tandem heart, which are used in during the short-term PCI therapy, where the patient is in cardiogenic shock, and they have been found to be very effective during these procedures. The current trends and status of minimally invasive cardiac surgery is these are new directions in cardiac surgery, where smaller and more directed limited incision is required to access and repair only the area of interest on the heart. Coronary artery grafting is also being done off pump without hemodynamic support of CBP or the still heart, achieved by using cardioplegia. Conduits for bypass are being harvested in a less invasive fashion using endoscopic technology. Robotic technology can sometimes allow taking down of lima, and can be done through trocar ports in the intercostal muscles. Currently, we are doing about 80% of coronary artery bypass surgery and nearly all valvular surgeries and ASTs and smaller VSTs through minimally invasive approach. I think we can practically do anything, any number of grafts through minimally invasive approach, and it should be noted that doing a simple coronary bypass surgery or valve surgery through a sternotomy in the current scenario should be taken as a punishment to the patient, and it should be avoided consciously, and there would be more effort given to the development of minimally invasive coronary artery surgery for simple cardiac surgeries. There are also development of enabling technologies that enable us to do better procedures during minimally access, such as the anastomotic enablers, which is done for either for the proximal or distals. The results of OPCAP against on-pump has been found to be little suboptimal, but however there are reports from various groups all over the world that say with experienced surgeons the off-pump surgery is equivalent to or better than on-pump surgery as regards to the loss of, and it results in earlier recovery of the patients with lesser blood loss, the absence of usage of coronary bypass or cardiopulmonary bypass allows earlier recovery and less systemic inflammation. Minimally invasive direct coronary artery bypass also can be done in a redo scenario where we just require a simple grafts to single vessels and can be used effectively through lateral and posterolateral incisions for various simple procedures. Usually in mid-cap surgery we don't require cardiopulmonary bypass. The incision is small and we don't cut the sternum. There is no usage of cardiopulmonary bypass, and we do a lima to LAD. We do also right intimal mammary also as a second graft, and we use vein grafts also, which are harvested endoscopically for other vessels. When do you refer patients for a heart transplant or LVAD? Usually when the patient has resistant symptoms and they are coming back to the hospital repeatedly despite maximum medical management, where no other therapies are improving the patient, then usually we think about destination therapy, LVAD, or a cardiac transplant. We also do a mixed venous oxygen saturation or a 6-minute walk test to find out whether the patient is actually requiring a heart transplant or not. Thus, a patient who has an NYHA class 3 or 4 symptoms, episodes of fluid retention and peripheral hypoperfusion, there is objective evidence of severe cardiac dysfunction, high filling pressures, and elevated beta natriuretic peptides. There is evidence of systemic organ injury such as liver and kidney, severe impairment of functional capacity, which is MVO2 of less than 12 to 14 milliliter per kilo per minute, and a history of repeated heart failure hospitalization in the past 6 months. So as time goes on, if we are not treating patients, those who are in grade 3, grade 4 heart failure, the mortality increases. It has been proved that a patient who has had a transplant or LVAD therapy has much better outcomes than a patient who is treated medically over a period of time in 5 to 6 years. And the benefit has been proved worldwide, and now it can be taken as granted that it's a procedure of choice where patients cannot be treated in a setting where drugs are not working. Usually the patients are highly dependent on inotropes. They require 2 or 3 admissions in the last 2 years. And if there is an ambulatory patient with a high risk profile for decompensation, usually we do a 6-minute walk test. And the introduction of left ventricle assist devices actually has improved survivals in the wait list of transplantation against a patient who is on IABP or inotropes. Thus, it proves good effects that the LVADs have given in a scenario of end-stage heart failure therapy in patients, those who require adult heart transplantation. So I think as we are very clear now that ambulatory, non-ambulatory or ambulatory patients with repeat symptoms, with repeat hospitalization, with less than 300 meters, 6-minute walk, and an intermax profile of 4 to 6 is actually a patient who would require an LVAD versus medical therapy, and LVAD has improved outcomes in these sort of cases as done by as has been shown by various studies, those who use LVADs as destination therapy also. Thus, as a conclusion, for the last 30 years, the only prognostic changing therapy for advanced heart failure has been heart transplantation. Start considering referral at initial signs of decline despite medical and electrical therapy. Current LVAD technology provides benefits for patients in intermax 2 to 4. LVADs demonstrated efficacy at a price of high complication rates, but they are necessary tool to improve survival in listed patients for transplant. It has been proved. Transplantation may provide benefit even for less sick patients also. A salvage therapy approach for advanced heart failure will never be a successful strategy. Early referral is required. Palliative care option is not an admission of medical failure, but must be considered an option of equal weight and should be part of the discussion of advanced therapeutic options. Thank you very much for your patient listening.